Okay, I think we're all good with the recording now. Sorry about that. Oh, Sarah, I think you're muted. Sorry.
Sorry about that. You actually missed my dog barking at least. So
Oh, no.
there's that benefit of having been muted. All right, let's try this again. Borderline personality disorder and good psychiatric management. I'm really excited to be here today to tell you about GPM. First off, I want to thank Lois Choi-Kane for many of these slides. The good psychiatric management community is kind of a small community. We're a small group of certified trainers and we share a lot of our materials. So I want to thank her and also just say that I have no conflicts of interest to disclose. Here's an outline of my talk today. So I'm going to tell you a little bit about BPD in terms of its prevalence, course, and functioning. And I know that many of you may already be familiar with this and that this may have already been covered in some of your previous talks. But here I'm going to focus on elements of BPD that are particularly pertinent to the good psychiatric management model. Then I'll say just the word about BPD treatments, their history and current problems before segueing into talking a little bit about GPM's evidence base. I'll also talk about the overall formulation behind GPM, the general principles of GPM, and because I know that you're all in medical school, I'll touch briefly upon GPM's approach to pharmacotherapy, but just as a caveat here, remember that I'm a PhD and not an MD. So I have things to say, but I can't go, I'm not going to know as much about, the molecular structure of these drugs or anything like that. And then I'll end with a note about comorbidity. And along the way, I will try to leave you with some kind of action-packed little snippets or tools that you can use in your practice. So just as a reminder of what BPD looks like, there are 9 criteria for BPD in the DSM-5. And of course, the DSM is moving likely to a more dimensional approach where we're going to see a reformulation of BPD according to the alternative model of personality disorders. But this is what it looks like so far right now. And you need 5 out of 9 of these symptoms. And just as a reminder, they include frantic efforts to avoid abandonment, which is real or imagined. A pattern of unstable and intense relationships that's characterized specifically by switching back and forth between idealizing and devaluing another individual. Identity disturbance. Impulsivity in at least 2 areas that are potentially harmful. So this would be things like reckless driving, binge eating can also fall into this criterion. Recurrent suicidal behavior and or non-suicidal self-injury. Affective instability, which is marked by mood reactivity. And of course, this is different than what we would see in bipolar disorder, both in terms of the time course of the affective instability, but also the antecedents of the instability, and also just the general phenomenology of it. The chronic feelings of emptiness, also inappropriate intense anger or difficulty controlling anger, and finally, transient stress-related paranoia or dissociation. Although you need 5 out of 9 of these criteria to meet the diagnostic threshold, there is good research by Andrew Chanin and colleagues and some others showing that at least having even just 3 out of 9 of these symptoms is associated with really significant functional impairment. So when we're thinking about GPM, we're thinking about applying it not just for folks who might be at full diagnostic threshold, but also folks who have maybe even just 2 of these symptoms or criteria. In terms of epidemiology, it's prevalent in about 1 to 3% of the general population. This applies to both adolescents and adults. You may see estimates out there as high as 6%, but that's likely an inflated estimate that was adjusted down to about 3% based on a reanalysis of the data. So 1 to 3% is actually quite prevalent if we think about this in terms of the general population. But then, of course, if we look in clinical settings, this is where the prevalence is actually really startling. And one thing that I hope that you can take from this and actually educate your fellow medical students about is that even if you do not intend to treat people with borderline personality disorder, even if you don't want to, you are going to have patients with BPD. There's no way around that, because the prevalence in outpatient settings, 8 to 18% in adults, inpatient settings, 20 to 25%. And then if for patients presenting to the emergency room with suicidal ideation, over half of them will meet criteria for borderline personality disorder. So you will interact with these patients. And that is why I think that every medical student, every physician should have education about BPD. Now, of course, over half of the folks presenting with suicidal ideation have BPD, and suicidality is a big component of BPD. So about 80% of BPD patients will engage in some form of suicidal behavior. They have on average a number 3 suicide attempts in their lifetime. And even if they're just engaging in self-injurious behavior without intent to die, that does increase suicide risk by 2 to 30 times. The rate of suicide is 3 to 10%, which is 50 times greater than the general population. And BPD is associated with a high percentage of all US suicides for both adults and adolescents. So suicidality is something that should be taken pretty seriously in BPD, and GPM does provide some great tools for managing suicidality. I'll also note that just in like the current context here, that if we think about BPD causing death, it's actually a lot more lethal than COVID-19 even. And I don't mean to downplay COVID by any means. The pandemic situation has been really trying for all of us. But, I think that what this highlights is that we need more kind of public attention and awareness about BPD, and we need broader training so that we can make sure that this disorder isn't as lethal as it has been. There is hope, however, if we look at BPD's longitudinal course, and I'll show this chart again, actually, when I start to talk more about GPM. If we look on the y-axis, we have the number of criteria that are met, so that shouldn't go all the way up to 10, it should only go to 9. And on the x-axis, we have the longitudinal course in terms of years. And you can see that the number of criteria met over this 10-year period does decrease. This was a large sample of people with BPD. And of course, the inverse of that is that as these symptoms are decreasing, the percent remitted increases. So this is just kind of a naturalistic longitudinal course. Some of these people will have had treatment, many of them will have not. And this suggests that BPD is a disorder that will naturally improve over time. And that might be kind of counter to some of the things you may have heard about BPD in the past. And this is a message that we share with patients. I'll come back to that. However, this picture is a little more complicated, because if we look at functioning over time rather than just symptoms, this is another large study that just focused on the GAF, which is a pretty crude instrument, but the finding still holds that functioning for BPD is lower than folks with obsessive personality disorder, obsessive compulsive personality disorder, and major depressive disorder over a 10-year period. And it's pretty flat, right? We're not seeing a lot of kind of natural improvement in functioning, although symptoms may be improving. And so this is a question in GPM of, how do we kind of facilitate the natural improvement of BPD symptoms while also improving functioning for folks? So psychosocial impairment is relatively stable over time. And if we compare BPD to other disorders, including other personality disorders, major depressive disorder, bipolar, schizoaffective, and the old axis 1 disorders, we see that there's significant functional impairment. Oftentimes the changes in BPD symptoms do affect the functional level on the individual scale. We see poor interpersonal functioning in BPD relative to these other disorders, and more negative life events and stressors in BPD. So all of this so far has kind of been me saying, this is why you should care about BPD, right? It's associated with high rates of suicidality, and it's associated with poor functioning generally. This is a slide to say that even, again, if you're not planning to treat people with BPD, I want you to be concerned, because This is a study of 210 patients with anxiety and depression. They were followed for 30 years. And all patients who had personality dysfunction at entry had worse outcomes in terms of total psychopathology, anxiety and depression, and social functioning compared to those with no personality disorder. And what this suggests then is that even if you're treating someone with anxiety or depression, if you're not addressing personality dysfunction when it is present, you're likely not going to be able to help that person in the long term with the anxiety or depression. It's more likely to recur and to be a longstanding issue. The personality dysfunction itself is going to accentuate poor recovery, such that if you're not addressing it, then you're probably not doing all that you can for your patient. And so I'm so glad that you're all here to learn more tools for helping people with personality functioning. If we look at trajectories in functional impairment, I'm going to parse this slide apart a little bit. It's a little tricky. So the people in orange represent people with BPD. People in blue represent people without BPD. And then the size of the person actually represents their age. So we have 4 groups here. We have on the left, folks with persistent PD. They had personality disorder as adolescents, and that's persisted into adulthood. Then we have adult onset personality disorder, where the BPD was not present when they were young, but then as adults, they have it. Then we have personality disorder in remission, where it was present for them as adolescents, but then as adults, it's they're not meeting diagnostic criteria. And then we have no personality disorder throughout. And this is a continuum where we see that the folks on the left have the highest impairment and the lowest functioning, okay? And what I want to point out to you from this is probably no surprise, right? That the folks with no personality disorders throughout would be on the right and the persistent would be on the left. But what this does suggest is that if we can get folks into remission, right? Or perhaps if we can intervene earlier to get them into remission earlier, then they're going to have probably better functioning, right? And this is maybe somewhat at odds with some of the information I gave you before, but this is also if we're really focusing on functioning, right? So we need to help folks hone in on social and occupational functioning to improve. And this is an argument for earlier intervention. Now, just another quick note about earlier intervention, because this is an increasing focus actually for folks working on GPM. The trouble with BPD begins pretty early. There's a developmental kind of fall off. So for years, people have used the information that BPD traits have a normative increase in adolescence as a reason not to diagnose BPD in adolescents. Because if you have an adolescent at home, or perhaps you have an adolescent sibling, you know, right, that like a 14-year-old has some elevations in things like impulsivity and affective instability, right? So there is a normative increase in BPD traits. But actually what we see is that for most kids, if we look at the lighter blue line, those traits will peak at age 14 and then decrease through age 18. Okay? But we do see a separate group, a separate identifiable group, where they have a peak, it's greater than their peers. They have that peak of symptoms, and then actually they do not have that normative decrease in symptoms, which means that the distance from peers increases. They have more BPD traits than their peers, and that persists over time. So for this subset, BPD traits remain persistently high beyond adolescence, and they can fluctuate depending on treatment and life events, et cetera. So we need to intervene for this subset of kids who continue to have problems and don't experience kind of the normative decrease in BPD traits. A few notes about a little bit more about why you should care about BPD. And these things also help support GPM's focus on life outside of treatment and on occupational and academic functioning. So BPD does predict academic functioning. BPD features are associated with lower GPA, number of semesters on probation, and percent who are ineligible to re-enroll due to academic reasons. People with BPD have over 3 times the odds of having only a high school diploma and less than half the odds of having graduated college compared to folks with major depressive disorder. And remitted people with BPD are more likely to have good work and school performance and a sustained work school history versus never remitted people. So we need to get people into remission. So in particular, when we look at specific symptoms or subsectors of BPD, it seems to be the self-harm, impulsivity, and affective instability that account for most of the variance in academic achievement and social maladjustment. BPD also predicts occupational functioning. So traits are associated with things like conflict at work, dismissal or demotion, unemployment, disability, even when controlling for depression. Also associated with likelihood of past month disruption in their role functioning or disability, lower educational attainment, and lower rates of full-time improvement over 10 years, even above and beyond avoidant personality disorder, obsessive compulsive personality disorder, and major depressive disorder. Compared to folks with other psychiatric diagnoses, people with BPD have 32% lower odds of working 9 years after their diagnosis. This next box again covers that remission has a positive message here, where remitted patients are more likely to have good and sustained work and school performance. One thing of note, this is an important point for GPM, is that the evidence suggests that poor occupational functioning actually is responsible for, or to blame for in some ways, failure to recover. So if we can get folks functioning pretty well occupationally, that has really good consequences for recovery. So GPM has a focus on work, and I will come back to that. And this is why it seems that it's not recovery that comes before occupational functioning. It's the reverse, that we get people out there, we get people involved in activities where there's good social learning experiences, where they have opportunities for positive feedback, and that's what helps them to recover. And we also know that if we look at the health effects of BPD, that work can actually help buffer against those health effects. And I'll say something about the health effects in a moment. BPD also predicts romantic functioning, including increases in interpersonal problems, the likelihood of being unmarried or separated or divorced, romantic dysfunction, verbal aggression, level of violence in the marriage. And people with BPD, I want to emphasize, are often the victims of this violence within marriage. Okay, so I know there's a lot of stigma about BPD and the anger that is part of BPD, but actually we want to keep in mind that folks with BPD are often in these relationships that are unstable, and they're actually in danger themselves. And it's also associated with lower marital satisfaction. Now, unlike when we look at occupational functioning, it seems that improvements in friendship and family relations kind of parallel improvements in BPD. So it's not that having a better relationship with a spouse or having a better relationship with a sibling is going to cause improvements in BPD, as we might expect with occupational functioning. These things actually improve together. So keep this in mind as well for thinking about the principles of GPM. And then finally, BPD predicts physical health as well. So it's associated with obesity, the use of both outpatient and inpatient services, physical and mental disability, and overall health-related functional status. And again, remission has a positive message. So folks who go into remission are less likely to suffer from what's been termed poorly understood medical syndromes, obesity. They're less likely to use expensive forms of medical care. So there's certainly kind of a public health kind of cost savings to remission here. They're less likely to quit work or to lose their jobs due to ill health, and to make lifestyle related choices that are bad for their health, including smoking, use of alcohol, etc. So just a word about treatment in general. So now that we know that BPD is associated with all of these negative outcomes, what's been done about it? So I'm just going to touch a little bit on the history of evidence-based treatments for BPD. I know you've had presentations at this point on both dialectical behavior therapy and transference-focused psychotherapy, and I won't talk much about them, but they are, they're in this alphabet soup of acronyms here. So in the 1990s, early 1990s, this is where we really started to build an evidence base for supporting treatments for BPD. Marsha Linehan's seminal book was published in 1993. And much of the treatment research during this time compared what we think of as specialized treatments. So DBT and TFP are both highly specialized treatments that require a great deal of training and that are really focused on BPD. What those types of specialized treatments were compared to what's called treatment as usual, or TAU. And treatment as usual is a really heterogeneous category. It's basically whatever you might get when you go into any kind of clinic, or you sign up for any kind of clinician. It's whatever they're giving you. And of course, that could be any range of types of interventions. But the early trials compared the specialized treatments to treatment as usual. And then in the 2000s, we saw a little bit of a switch where now many of the trials actually were head-to-head in that they compared the specialized treatments to one another. And then in more recent research, what we've seen is this shift to compare the specialized treatments to structured generalist treatments. So this is where GPM comes in. General or good psychiatric management, you can call it either one. There's been debate among GPMers about which is the better title. But general psychiatric management is a structured clinical approach. It's not specialized. And what that means is that it doesn't require a great deal of training. It's meant to be accessible to someone who has clinical training and knows a little bit about BPD, but who isn't ready to commit thousands of dollars and lots of training to become proficient in a specialized treatment. The GPM trainings often, the introductory one is just a day long. GPM trainings are free. It's meant to increase accessibility. Now, it's different from just general TAU in that it does have some focus on BPD. So it uses general, what we know generally as good approaches within psychotherapy to help people with BPD, but it's not as specifically specialized as dialectical behavior therapy, for example. SCM is another one. This is structured clinical management, and this is one that is much more common in the UK, and it's the one usually compared to MBT. But in recent clinical trials, what we've seen is actually that these specialized treatments are compared to these generalist models, which are probably better to compare to than something like TAU, because TAU is kind of like a really low bar if we're thinking about validating a treatment. And this is a meta-analysis that looked at much of this research. And what it found is that there were small to moderate effects for standalone designs. So this is where you would be comparing like a specialized treatment to treatment as usual, and non-significant results for add-on designs where you're adding something onto the specialized treatment. They found actually that different types of psychotherapies, there weren't any significant differences overall in this meta-analysis for BPD. And there were no differences between experimental and control groups in terms of treatment retention and treatment intensity wasn't related to treatment outcomes. So some people sometimes think that, oh, DBT must be like the treatment that you should absolutely do because it's so intense, right? You have the group sessions, you have the individual sessions, you have the calls in between sessions. And it's, it's really intense and you jump right into it. Of course, that's going to lead to better treatment outcomes. But meta-analysis actually suggests that may not be the case. So there are some problems that we have with the current state of psychotherapy for BPD. I want to preface this by saying that I think that we have good treatments for BPD, but this is just to say that they can be better. Okay. We have high dropout rates. So about almost a quarter of people with BPD will drop out of treatment across study types. And this is a paper that you may notice the reference in the bottom there that Evan actually wrote. So I feel kind of funny speaking about it, but so if you have questions about this slide, he gets to answer them. But what he found actually is that odds of dropout are not higher in control conditions than in intervention conditions. And dropout may be attributed to things like dissatisfaction, expulsion, and lack of motivation. And it usually happens in the first half of treatment. So this is something that we definitely need to be addressing when we think about psychotherapeutic approaches to BPD. There's also high rates of non-response. So in a meta-analysis of 28 studies with over 2,000 folks enrolled or across those studies, non-response was defined according to reliable change or in terms of no longer meeting the criteria for BPD. But the range was 6 to 100% of people didn't respond across these studies, with a mean of about 50%. So this suggests that these treatments might be useful for 50% of folks, but they're missing the mark for actually a high percentage of people. And this is not just specific to BPD. I will remind you that there's high rates of non-response for folks with OCD, and even like the best treatments for OCD too. So I don't need to take away from this that we don't have good treatments for BPD, because that's been something that actually has been a barrier to care for folks, is that belief that's persisted, because we do have these good treatments. Interestingly, and most pertinent to GPM, there were no differences in non-response rate for different treatment types, whether they're specialized or generalist. Okay. And this is another big problem with the current state of research. And you'll see that Evan also wrote this paper. So he's hitting it out of the park with these papers on BPD. The answer to the question in this title is a resounding no, right? Is supply adequate to meet public health needs? Absolutely not. That's why part of why I'm happy you're here to see this talk. And I hope that you can encourage your peers to get trained in BPD, because we absolutely need more people to help folks with BPD. So if we look at kind of general providers worldwide, in Australia, Netherlands, and Norway, there's 4 treatment-seeking patients with BPD per provider per year if every clinician managed BPD cases. So this is general clinicians, and that's a big if. In Turkey and Mexico, there's upwards of 70 patients with BPD per provider per year. And then if we look at specialist treatments, this is where it gets really messy and concerning. So remember, this is folks trained in things like DBT, TFP, mentalization-based therapy. In the Netherlands, which is one of the best countries in this review, there's over 600 patients per provider per year waiting to get in. Well, they're not necessarily a wait list, but who would be per specialist BPD treater. In South Korea and Mexico, if you're trained in a specialized treatment for BPD, there's 100,000 patients that you could see. For each and every specialized treater, 100,000 patients per provider per year. This is not a good scene, right? If we think about how associated BPD is with suicidality, how distressing and difficult this disorder can be for folks with BPD, how difficult it is, and also how much burden it puts on healthcare systems, because people with BPD are very high users of general medical services, including the emergency room, but not limited to the emergency room. So we need to think about ways to bridge the implementation gap, and to think about moving beyond just these specialized treatments to reach more people with BPD and to give them good clinical care. So we could consider, for example, a stepped care or clinical staging approach, where we have some combination of these things, and we're thinking about where to start people. So for example, there might be people who would benefit from going right to a specialist treatment. That's great. There might be people who would benefit from an abbreviated treatment, maybe just 6 or 12 weeks, from an add-on treatment where they're already seeing a clinician, but they get added into a group, for example. Especially in today's current climate, telehealth interventions may be really useful. Just general psychoeducation can be useful, and I'll talk about that. But generalist treatments, I think, have a big role to play in terms of a stepped care approach. Maybe we can start folks in generalist treatments and then think about transferring them to specialist treatments as needed, so that we don't need so many folks trained in these highly specialized ways to help people with BPD. Maybe we can get enough folks on the ground who have general knowledge of BPD and some good core clinical skills and tools at their disposal to help people, and to know when to refer them on. So GPM does rely on general principles of change that really are behind most or all psychotherapies. So first off, promoting the patient's expectation and motivation that therapy can help. Helping someone have hope that therapy is going to be useful is really the first step in helping them within the GPM model. And that's part of what psychoeducation is about. I'll say more about that in a moment. Establishing an optimal therapeutic alliance is, of course, really important. And there's some elements of the alliance in GPM that are maybe a little bit particular to that model. I'll say something about that. Facilitating client awareness of the factors associated with their difficulties. Again, this is about providing psychoeducation and being really transparent about the formulation that you're using. Encouraging the patient to engage in corrective experiences outside of therapy, and emphasizing ongoing reality testing in the patient's life, which again requires this focus outside of therapy. So let's talk specifically more about the GPM model. This is a picture of John Gunderson, who developed GPM. He died a couple of years ago, but I like to keep the picture in because it's a good reminder for me of how passionate he was about this. Before I talk about the model, I will point you to these resources. And again, I have no conflicts to disclose. So if you buy these, it doesn't benefit me, but I highly recommend them. The book on the left is a great kind of concise handbook for adults, for treating adults using GPM. The one in the middle, it just came out actually. I wrote a chapter in this on family interventions. And that's for adolescents. And then there's, if you want to read more, the applications is a longer book. The first two books, the red and the blue books, are really concise books. They're written in plain language and they're meant to be, Good Psychiatric Management is meant to be accessible not just to the patient, but also to the clinician. So they're written in plain language and they have lots of tools and tricks and lots of like bubbles that have basically like, this is the language you can use, right? Like this is what you can say. So they're just really useful in general, I think. So the evidence base for GPM. This is an article in the American Journal of Psychiatry. Remember that I said that there was this, the newest kind of treatment wave or RCT strategy is to compare a specialized treatment to a generalist treatment. And this was a study that did just that. It compared dialectical behavior therapy to good psychiatric management. And one thing that's notable about this study is that even Marshall Linehan has said that the DBT in this study was good DBT. And we know that the GPM in this study was good GPM. So these were good quality interventions put head to head, and about 180 patients went through this trial. And, as they're testing DBT against GPM, what they're hoping to find is that dialectical behavior therapy outperforms GPM. Because if you're spending the amount of time doing training for DBT that it requires, you'd like to outperform the folks who are doing a pretty short training and using kind of general approaches, but that's not what they found. So if we look on the left at suicidal episodes across 12 months, the frequency decreased for both groups and there were no group differences. So GPM did just as well as DBT in decreasing suicidal episodes over a year. On the right, there's no group differences here. So although those two dots out at 12 months might look like they're significantly different, they're not. So we saw a decrease in both in suicidal episodes on the left and non-suicidal self-injury on the right. So DBT and GPM performing similarly. If we look across a longer time, this is out to 3 years, and also across a broader range of outcomes, we see a really similar story. So we have symptoms on the XAN-BPD, we have quality of life, we have symptom distress, we have anger expression, we have depression on the BDI-2, and then interpersonal functioning. What you see here is that both treatments they're seeing improvement in all of these domains, and there's no group differences. Good Psychiatric Management is performing as well as DBT across all of these outcomes across 3 years of follow-up. So this is a really great suggestion that, and I'm not going to denigrate DBT at all. I love DBT. Like I have training in DBT and I think it's a really great treatment, but this is a great suggestion that GPM might be a really useful tool for increasing access to care. So let's talk about GPM's formulation. GPM is based on a model of interpersonal coherence or interpersonal hypersensitivity. Now, it uses kind of a common factors approach where the interventions are actually built on many of those general principles of psychotherapy. But where it gets really specific to BPD is through this model. So all of those interventions are linked to the interpersonal hypersensitivity model in one way or another. And so what it suggests is that when someone with BPD feels connected, that could be to you as a therapist or to a close other, they're in the state of kind of idealizing and dependent. But when there's an interpersonal stress, this may cause them the relationship to feel threatened and actually put the individual in a threatened state, where we see things like self-injury and anger. Now, self-injury and anger often cause another individual to withdraw, right? It's sometimes really hard to deal with someone being really angry with you, right? So withdrawal is kind of a natural response to that. The problem here is that withdrawal by the other actually can lead the individual with BPD down into a state of aloneness, where some of the more impulsive and paranoid symptoms come online. Then if there's lack of holding, so there's further withdrawal and there's no holding environment, that's where we start to see despair and suicidality. If at some point a holding environment is reinstated, and oftentimes this happens when the person who is despairing and suicidal ends up in an emergency room, and then their loved ones are coming in because they're really concerned, right? Or they're actually in a literal holding environment because they can't leave the hospital, right? Then the person might feel a sense of support and may return to this initial state of feeling connected where they're idealizing and dependent. So this is a model that is presented to patients in GPM. So we're totally transparent about this formulation of the problems of BPD. And it's a model that's really useful because then you can actually help predict what's going to happen during interpersonal stressors, right? And it's a model that you can go back to and look at, and you can kind of trace what happened, maybe when someone has engaged in self-injury or has become suicidal. And we can also use this model to think about where to intervene, right? And one way to intervene is to really, lean in at a particular point. Of course, forgive me. This is why I don't like typically having animations in slides, because they can be a pain to get through when you mess up. So one place where you're going to intervene is to actually lean in at this point, where someone is threatened and is maybe engaging in self-injury or anger. And so this is something where anger can be hard to manage in the therapy room. For me, actually, when I'm treating people, I actually for some reason do a lot better with anger than something like grief. But for many people, it's hard to have a patient in the room angry with you, right? And it makes you want to do this thing of withdrawing. But one point here is to really lean in and help kind of use this model to understand the anger and to kind of think about the interpersonal stress, but to help kind of keep this person in the supported state. Because another thing that's important is that in these top two states, patients tend to be more trusting. And this is actually where therapeutic progress can be made because they're able to integrate information. But if they slip down to these states, this is not the place where therapy is actually going to be useful because they're in this mistrustful place where the information is not going to be processed. And they're hard to reach. Okay, so this is the general model. Let's talk about some principles that are under the hood of actual GPM. So I'll talk about these 4 areas. Diagnosis is really key to GPM. John Gunderson was this wonderfully kind of blunt person, very frank. He would really say it like it was, and this cartoon works really well for him. And he was a big advocate for making the diagnosis as early as possible when appropriate. So lots of people actually sometimes have concerns about making the BPD diagnosis, and that's understandable because of a lot of the stigma that still surrounds the diagnosis. But what we know actually is that When you give people the diagnosis, it actually tends to lead to things like better hope and overall sense of well-being when it's delivered appropriately in a way that's validating and warm and affirming and collaborative. Okay. Here's some more. So you might say something like, this means you're born with a disposition for BPD. We think you are hypersensitive in ways that would make it difficult for others to respond helpfully. So when you're giving the diagnosis, you're also giving a little bit of psychoeducation and being really clear about why you're giving the diagnosis. One tip that I have for giving the diagnosis is actually to open the DSM with your patient. And I know that you might not do this. Like, I don't know if, physicians have, for example, like a manual of diabetes, right? You wouldn't necessarily like open that manual and talk about it with your patient, but do this with the DSM and BPD. Go through those criteria, make it really transparent. Talk about how the person fits the criterion or how the criterion fits the person and how it doesn't. Get examples, elicit collaboration. That will help someone really feel validated in getting the diagnosis. And we know that when the diagnosis is delivered in that way, it leads to good outcomes. So people are equally as satisfied with the evaluation as when they get a different diagnosis. Diagnostic disclosure is often identified as a turning point in helping people conceptualize their experience. It brings validation and relief. And despite all of this, the gap between age of BPD onset and age of diagnosis was 15 years in one point. And I've seen folks in their 40s, 50s, 60s who just got the diagnosis and they were treated for the wrong thing for years, either because clinicians or physicians didn't want to give them the BPD diagnosis, so they gave them something else, PTSD, bipolar 2, schizoaffective disorder, right? Or because it wasn't recognized and they got inappropriate treatments because they didn't get the right diagnosis. So making the diagnosis is key. I could stand on that soapbox for hours. So if you have questions at the end, I'm happy to talk about that. Psychoeducation. So making the diagnosis is key to psychoeducation because then you can teach people all about BPD. And one thing you might want to start with is talking about the longitudinal course, instilling the sense of hope. BPD has a naturally remitting course, and the role of GPM is to facilitate or catalyze this natural longitudinal course. How can we make sure that you're one of the folks who gets better, and how can we make that happen faster? We're also frank about limits to changes in functioning over time, and really clear that GPM is going to focus on functioning to help account for this, okay? Psychoeducation also focuses on etiology, talking, for example, about the high heritability estimates, which average about 55%. Treatment options, talking about things besides GPM. And the interpersonal hypersensitivity model is made very clear and transparent from the get-go. I'm going to try to go fast here, running out of time. A quick note that there's good evidence for psychoeducation. So just giving like a 6-session GPM group that's focused on psychoeducation itself improves symptoms. And that improvement is sustained at 2 months. So compared to wait lists, we're seeing that a much higher percentage of folks are getting better just by learning about their BPD. And this is another study that compared internet psychoeducation versus a control group. And again, there's great evidence that the psychoeducation itself was useful. So if we just think about the psychoeducation as its own kind of component, separate from GPM or any other treatment, it's a great place to start. If you're only going to see someone for 1 or 2 sessions, just focus on the psychoeducation. And it's likely to provide some relief or improvement. GPM has this principle of accountability to change. So because it's built on this idea that it's going to catalyze that natural course of improvement, there's an expectation that there will be change. And so you may say something to your patient like, we will only continue treatment if it is actually working. And I need you to help me know if it's working. So what would it mean if it were working? What would that look like to you? What can we track? How can we know if what we're doing here is helpful? And if it ceases to be helpful, then treatment ends, and you might provide an appropriate referral to something else, but you're not going to continue to do something that's not working. That accountability for change is really key. It also has a focus on getting a life. So many folks with BPD are very concerned about interpersonal relationships. because of the attachment considerations that underlie BPD, and also the difficulties that folks have with interpersonal relationships. But John Gunderson would always say that you need to get a job. So the maxim here in GPM is work before love. And remember, I said, as we were going through BPD's association with different levels of functioning or types of functioning, that evidence is what supports this, which is that occupational functioning actually seems to help people improve with BPD. Okay, so the idea here is to focus on life outside of treatment. The relationship with the therapist is, of course, really important, but only to the extent that it can facilitate someone functioning outside of the therapy room. And getting a job is a great start for that. And here you could be a little liberal with what you mean by job. It could be like a volunteering experience to start, for example. And for teens or adolescents, you'd be thinking the maxim would be academics before love, school before love. Okay. A quick note about state of pharmacotherapy, that there have been few RCTs have been conducted, and they have some problems when we're thinking about BPD. But what we do know is that no medication is uniformly or dramatically helpful for BPD. None is licensed by the FDA, although of course I know you can use things off label. And pharma-sponsored research has been limited by fears of violent or suicidal acts and associated liability. So oftentimes the most severe patients are not included in trials, which is a big problem. And this is key also, that the number of medications is inversely related to improvement. I've seen patients come in with a med list 10 to 12 deep, many of them, most of them psychotropics, and that's a red flag for me. It's a red flag for me that someone may have been chasing symptoms without thinking about personality function or the BPD itself. It's a red flag for me that they may have more trouble improving. Folks on more medications are less likely to improve when they have BPD. So the idea of GPM is to build an alliance and to use that alliance to use medications really sparingly to help the patient understand that medications are adjunctive to psychotherapy. BPD is a disorder of interpersonal hypersensitivity, which is to be approached more kind of from a psychotherapeutic stance. Emphasize the need for collaboration. Again, identify target symptoms for medications and think about how to collaboratively monitor whether medications are working. And then also some guidelines. So if a patient requests medications and they really want a medication, sometimes it's better to offer an SSRI because of the low side effect profile, because there might be some small gains in the context of BPD. The general caution is not to jump to things like mood stabilizers or antipsychotics, although they can have some use in the context of BPD. Those books that I showed you have really great decision trees for understanding when to use particular medication classes and for which symptoms. So I would definitely check those out. If a patient is depressed but doesn't want medications, then you would encourage but not push the use of medications. Avoid a dichotomous stance with meds. So you can say something like, I'm not certain if medications will work. They may be helpful, but it's important that we monitor their usefulness. And that maybe if something isn't useful, then we stop using it. And that seems really basic, right? But it often doesn't happen in practice. So that's why I put it in here. I'm going to skip through these slides just in the interest of time, but I'm happy to share the slides. And of course, they'll pop up in the recording. But just to note that there does seem to be a significant placebo response, and that people with BPD may be particularly susceptible to this placebo response. And this study that I don't quite have time to talk about looked at lamotrigine or Lamictal for people with BPD compared to a placebo. Okay, quick note about complex comorbidity. This is important. When do you prioritize BPD versus something else? So in the GPM model, the idea is to prioritize the comorbidity when it precludes involvement or active learning. So if someone, for example, is anorexic and doesn't have the proper nutrition to have good cognitive functioning, then you're going to prioritize the eating disorder. Same thing with mania, substance use, etc. You prioritize BPD, however, when the comorbidity is unlikely to remit or likelier to recur unless BPD is in remission. So this is the case with things like depression, anxiety, and other disorders, where they're not likely to get better long-term unless you address the underlying personality disorder or personality dysfunction. Okay, and that can also relate to bulimia, social phobia, and remitted bipolar disorder. In some cases, you may want to consider stabilizing borderline personality disorder before addressing the comorbidity so that you can increase the patient's ability to tolerate exposure. So this would apply in cases where the primary psychotherapeutic intervention is behavioral and focused on exposure. So folks with panic disorder, PTSD, and OCD, many of the evidence-based treatments there are very exposure-based. And in these cases, you would want to make sure that the BPD itself is stabilized before going into that exposure. So I want to leave you with this question that I think folks who care about GPM are really passionate about, which is how can you ensure that people with BPD get the help they need? One thing is to kind of catch stigmatizing beliefs or ideas when they come up and address those. Another is to make sure you're making the diagnosis. Another is to educate your peers about how prevalent BPD is and how important it is to identify it when it's there. Another is to provide that psychoeducation. And another might be, and this is, again, no conflict of interest. I have no benefit whatsoever from promoting this, but there's a free online, it's not free anymore, sorry. It's inexpensive. There's a $25 online training for GPM available through Harvard Medical School. And I really encourage you to do this and to encourage your peers to do it as well. I could only really skim across some general principles of GPM, but I want to emphasize that it is this generalist, no nonsense approach that's not meant to require really intensive training, but it will help you in your patients, helping your patients with BPD and just with general clinical skills. So I definitely encourage this. And if you're interested in other trainings, the Gunderson Personality Disorders Institute at McLean is offering a whole bunch of them. None of them are as inexpensive as the GPM training, but you can go to this link through the McLean website to access more information about each of these trainings. Thank you.
Thank you so much, Sarah. That was really informative and I think helpful for medical students. I was wondering, does anyone have any questions for Sarah? Would you mind staying on for a couple of minutes to answer questions?
Yeah, no, of course. Sorry, I
you.
pushed us right to the last second there.
Also to encourage, oh, sorry, go ahead.
The
I was just
web link is different. I tried logging to the one that you gave us. It took us to a login Harvard Crimson page. This is the one that didn't require a login when I Googled it.
Oh, did I give you the wrong link?
I think it might be an old link that took you through
Okay.
like a Harvard login. This one didn't require a login. But thank you very much for the presentation. It was really interesting.
I'm just going to turn off the recording so that people's questions are not immortalized. One moment.